Does it work? Yeah, good. It's my pleasure to introduce today Dr. Katie Cobb-Pitstick, who is a graduate of the University of Cincinnati College of Medicine, and then the pediatric Sorry, I won't start again. Don't worry. And then the pediatric residency and child neurology residency here at Children's Hospital of Pittsburgh. She then did a fellowship in headache medicine at the University of Pittsburgh at the University of Pittsburgh Medical Center, and then joined us as faculty as an assistant professor, being our headache specialist. She's brought new insights, new knowledge to our patients. She's also brought some procedures, Botox and nerve blocks and new medications to patients with headache and migraine problems. Interestingly, she has a joint appointment with the adult neurology division and spends 1/3 of her time with them and 2/3 with us. And this is a great synergy between adult neurology and child neurology. She is the director of medical student education within our division and is also the assistant medical director of the neurology clerkship rotation at the university. She teaches extensively, including developing curricula for multiple levels of learners. She has published several articles in her field. She is doing clinical research in this area. And she has also obtained extra education in quality control, quality initiatives, and she is doing those in our area, in our division. Today, she's going to talk about migraine, the most common neurological disorder in children, and we'll talk about migraine epidemiology, diagnosis, and treatment. Katie, thank you.
Thank you, Dr. Bergman. Can everyone hear me okay? So the title of this talk is First Contact Migraine Pediatrics. So First Contact program was developed by the American Headache Society to educate primary care providers and other providers who are that first point of contact for children and adolescents who present with migraine. I don't have any relevant disclosures for this talk. The goal here is really to empower providers who are caring for migraine, which is a very common and disabling disease. So first, we will talk about how to recognize and diagnose migraine, how to explain migraine as a disease to patients and review its prevalence and disability. We will review how to differentiate primary from secondary headache disorders, how to identify when patients may need further workup or subspecialty involvement, and then finally develop a toolbox for how to treat this disease. And then we'll highlight developments in the field, especially with regards to newer therapeutics that are on the way. This is an overview of the topics that we'll go through. And we'll start with the question of what is migraine? Migraine is an inherited neurological disorder that's characterized by sensory, autonomic, vestibular, cognitive, and gastrointestinal symptoms. Often, migraine is equated to a really bad headache, but in reality, all of these other symptoms that accompany the head pain are just as much migraine. For some, headache may not even be present at all in the migraine, or at least is not the most bothersome symptom for these patients. Migraine occurs over 4 phases. It starts with premonitory symptoms. So this phase involves activation of the hypothalamus and the neurotransmitter dopamine. You'll see symptoms such as fatigue, cognitive slowing, irritability, or other mood changes, neck stiffness, recurrent yawning, food cravings in this phase, which sometimes can be mistaken for a trigger for their headaches. And then these symptoms can occur a couple hours up to a couple days before the onset of the head pain itself. The second phase is the aura phase, which is experienced by 15 to 30% of migraineurs. And this is associated with a phenomenon of cortical spreading depression across the surface of the brain, and this leads to hyperexcitability of the neurons. Aura symptoms are fully reversible. They last for 5 to 60 minutes. The most common type is going to be visual aura, and then the head pain may start either during the aura phase or shortly after the aura resolves. The third phase is the headache phase, and so this correlates with neurogenic inflammation, leading to irritation of the pain-sensitive structures of the brain, like your vessels and meninges, altered functioning in multiple anatomic structures, including your brainstem, thalamus, hypothalamus, and multiple areas of the cortex. There are a lot of chemical mediators that have been implicated in this phase, including serotonin, CGRP, nitric oxide, among others. And then symptoms during the headache phase are those symptoms that you classically associate with migraine. So that pounding, throbbing pain, heightened sensitivity to lights, noises, smell, autonomic symptoms like flushing, pallor, diaphoresis, and then significant GI distress like nausea, vomiting, abdominal pain. And those are often the prevailing features in pediatric patients. And then the fourth phase of migraine, which is often referred to as the headache hangover by patients, is correlated with persistent blood flow changes and those reabsorption of inflammatory mediators that were released earlier in the migraine. And these symptoms can last for a day up to a couple of days after the headache pain itself resolves. So migraine pathophysiology is very complex. It used to be considered a primary vascular phenomenon, and that is no longer the case. Attacks, as we mentioned on the previous slide, start with this dysregulation of the hypothalamus, and then you get this wave of cortical spreading depression, hyperexcitability of the cortex, which then leads to activation of the nerves in the dural vessels, leading to release of neuroinflammatory mediators like CGRP, which then causes vasodilation and extravasation into the surrounding tissues, leading to further irritation of the nerves that feed back into the brainstem via trigeminal nociception, and then propagate this signaling throughout the higher brain regions. So there's still more to discover about migraine pathophysiology, in particular about where that primary source of pain generation is, but we have come a long way in understanding different areas that are involved. The biggest issue practically with migraine is the prevalence and the degree of disability associated with this disease, including in pediatric patients. So we know globally that 1 billion people suffer from migraine. It affects 1 in 5 adult women, 1 in 16 adult men, and 1 in 11 children. Early presentation of migraine may vary depending on the age, and there are several episodic syndromes that have a relationship or may be predictive of migraine in the future. Children with migraine have been found to be 6 times more likely to have experienced infantile colic. And in a more recent study by Dr. Amy Gelfand, mothers with migraine were found to be more likely to have infants with colic with an odds ratio of 1.7. Benign paroxysmal torticollis is a well-known episodic syndrome, usually occurs in infants where they present with an uncomfortable tilt of their head associated with irritability or ataxia, and that usually resolves within hours. Benign paroxysmal vertigo is a more profound presentation in toddlers or preschool age kids where they have attacks of sudden onset dizziness and autonomic features lasting minutes to hours. Cyclic vomiting syndrome is very dramatic, presents in younger school-age children where you have these typically nocturnal attacks of unremitting vomiting that can last hours to days, often requires hospital presentation or admission for rehydration. And then abdominal migraine, which may present around age 7 with a migraine attack, but without the head pain, but they have more periumbilical pain that's associated with those other typical migraine features. So as discussed on that slide, migraine may start as early as infancy. But when you ask adults with migraine when their headaches usually start, many will say that it's between 8 or 9 years old. And prior to age 6, males and females are roughly equally affected. In some studies, the prevalence is actually a little bit higher in boys compared to girls. Closer to puberty, there's a marked change in the prevalence of migraine, which becomes much more likely in females compared to males. And this is a trend that continues throughout adulthood. So migraine is associated with a lot of common pediatric conditions. Asthma, hay fever, frequent ear infections, these are all more common entities in children who have headaches. And then there was a 2021 study that was published in the Electronic Journal of General Medicine that looked at over 5,000 kids, and they found that the risk of migraine is significantly higher in kids who have asthma. When you compare the prevalence of migraine to other common pediatric disorders, you see that migraine at a prevalence of 9.1% of kids occurs at very similar rates to both ADHD and asthma. But in clinical practice, migraine may not be perceived at this rate by providers, and because it's underrecognized, underdiagnosed, and as a consequence becomes undertreated. And this contributes to this huge problem of disability. Based on the World Health Organization's Global Burden of Disease study in 2019, headache is the leading cause globally of years lived with disability between the ages of 15 to 49. For children, we see disability in school and extracurricular activities. So compared to those without migraine, children and adolescents with migraine miss more school days, they have poorer school performance, decreased family and social interaction, decreased involvement or suboptimal performance in their sports and leisure activities, and an overall decreased quality of life compared to their peers without headache. So it becomes critical to really make an appropriate diagnosis for these kids so we can intervene early and get them feeling better and more functional. When considering a patient who's presenting with headaches, you want to know, when did the headaches start? When did they become a problem? And how did the headaches change over time? Reassuring patterns include patients with acute recurrent or episodic stereotyped attacks, and then chronic non-progressive, where they may have a higher frequency of headaches, but severity fluctuates and overall the headache pattern is stable over time. More worrisome patterns would be chronic progressive, so headaches that are just gradually getting worse over time, and this can be concerning for entities like tumor or increased intracranial pressure. Acute or thunderclap onset headaches, that would be dramatic presentation, first and worst headache, and those would be concerning more for a brain bleed, like a ruptured aneurysm leading to subarachnoid hemorrhage, and that's an emergency. New daily persistent headache. This is a new onset headache that quickly becomes unremitting. This is a primary headache disorder. It can be seen in most cases without a clear trigger, but it can also be seen following head trauma like concussion or after an infection like COVID-19. It's also important to rule out other secondary etiologies like a sinus venous thrombosis with entities like this. And then even in patients who have a stable primary headache disorder, if they have a change in the pattern of their headaches, that would also prompt you to consider additional etiologies. The clinical priority of that first diagnostic evaluation is really to identify the warning signs, including either in the history or the physical examination that would suggest a secondary headache. In the absence of warning signs, the headache is most likely a primary disorder, with the majority of primary headaches being migraine or tension type headaches, and much less commonly in kids, especially trigeminal autonomic cephalalgias like cluster headache. Examples of secondary headaches would include things like infection, which is very common in pediatrics. And in fact, more than 80% of headaches that present to the emergency department are secondary to an upper respiratory tract infection. Other secondary etiologies would be trauma, like a head or neck injury, vascular pathology like a stroke or vascular dissection, and then non-vascular issues like tumor. And even in the absence of warning signs, providers should be concerned in headaches that have atypical features, like a migraine with a prolonged aura more than 60 minutes, or a migraine that lacks the characteristic features that we typically see or doesn't meet all the diagnostic criteria, especially if it doesn't respond to typical therapies. Snoopy is a mnemonic tool that is used to summarize the red flag symptoms for secondary headache conditions. S stand for things like systemic symptoms, including infections or fever, secondary risk factors like immunodeficiency syndromes or cancer. N is going to be any neurologic signs or symptoms, including an abnormal fundoscopic exam. O for that sudden or thunderclap onset headache. There's also occipital listed here, which is a debatable entity. So we do know that children with brain tumors are more likely to report an occipitally located headache in retrospective data. But in prospective data, children who present with occipital headaches are no more likely to have a brain tumor compared to other kids. P is a lot of things. So pattern change, again, like we mentioned previously. So be alert for secondary causes, even if they have a prior diagnosis of a primary disorder. And then provoking features. So is it precipitated by position change, Valsalva maneuvers, or again, if they have that papilledema on exam. And then Y stands for younger age. So kids don't necessarily provide a reliable history, and you may have to be on higher alert for entities like a brain tumor in the younger age population. So just to reiterate, the red flag symptoms that would prompt emergency department evaluation would be that thunderclap onset headache, worst headache of their life, new onset intractable vomiting, particularly nocturnal or on awakening, any abnormal neurological exam, and when the provider's concerned, especially with those patients who have secondary risk factors for other issues. And then more yellow flags, which may need additional evaluation, but not necessarily urgent, would be those younger age patients, the new daily persistent headache pattern or a change in their headache pattern, side-locked headaches that may be more reflective of trigeminal autonomic cephalalgia, which needs additional workup, and then headaches causing nocturnal awakenings or Valsalva-induced headaches. So these are all entities that you'll typically proceed with additional imaging or other workup to find a cause. When you look at adults versus children with migraine, kids have a shorter attack duration typically, so between 2 to 72 hours compared to 4 to 72 hours in adults. And this is in reference to untreated attacks, and any sleep that is a consequence of a migraine attack is also included in the duration of the attack for both patients, both pediatrics and adults. Migraine in children is often more bilateral and bifrontal, so kids will typically point to their forehead, compared to classically unilateral pain in adults. Location, description, and the intensity of the pain, though, are important factors, but don't necessarily distinguish migraine from other entities. But aggravation by routine physical activity, nausea, vomiting, and sensitivity to light or noise, which often need to be inferred based on the kid's behavior, those are usually more sensitive for a diagnosis of migraine. Up to a third of patients with migraine experience an aura with their attacks. The diagnostic criteria of aura are very well defined. Typical auras are going to be visual, which is the most common. Other typical auras are sensory or language issues. They occur with a gradual onset over 5 minutes and typically last between 5 and 60 minutes. Note that generalized blurry vision is common in migraine and does not always mean aura. Motor and brainstem symptoms can also occur, but those are more atypical. And then other unusual features that need higher scrutiny for something like aura would be bilateral symptoms, too short or too long in duration, and the presence of weakness or amnesia to attacks. And so you may think of something other than aura in cases like that. There is evidence for and against neuroimaging in pediatric patients. Reasons in favor would be a primary parental concern when they come to clinic is the possibility of a brain tumor, less frequently a vascular malformation, but that comes up particularly when there's a family of an aneurysm or other brain lesion like that. Brain tumors are the second most common malignancy in childhood, and 1 in 10 kids with a brain tumor do present with headache as the primary feature. And then kids with recurrent headaches and an abnormal neurologic exam are much more likely to have a CNS lesion that does require surgical intervention. Reasons against imaging: CT scans expose kids to radiation. MRI scans are costly. Gadolinium contrast, when that is used, can accumulate in the brain over time, and we don't know exactly what the downstream consequences of this are. Many children need sedation or anesthesia to get good pictures, and this creates its own risks. And then incidental findings are really common, up to 16.4% of patients. And though you might find something incidentally and tell the families that it's not related to their headaches, families and patients often perseverate on that finding. Sometimes you do find neuroimaging issues that need additional surveillance scans or need subspecialty follow-up, and that can create new anxiety for the family or add to the overall cost of these issues. The bottom line regarding imaging is that there's no need to do neuroimaging in patients who have headaches consistent with migraine with a normal neurological exam and no atypical features or red flags. The Choosing Wisely campaign through the American Board of Internal Medicine is an initiative to reduce overuse and unnecessary testing or services across a wide range of medical specialties. Their recommendations for imaging in headache in children and adolescents are to not perform neuroimaging studies in patients with stable headaches that meet criteria for migraine. And when we think about stability, we're usually looking at over a 6-month time course. And then don't perform CT when an MRI is available, except in an emergency department setting. So if you're worried about acute bleed or a thunderclap onset headache, a CT may be appropriate. The American College of Radiology is also a good resource for imaging guidance on specific clinical scenarios. So patients who have an immunodeficiency or cancer, you can find recommendations on those particular issues. So now we'll move on into managing pediatric migraine. And I just want to reemphasize the importance of helping patients and families understand that migraine is a disease, and that is the reason that they're having headaches. And that can help them move on from trying to find another cause and be more invested in the treatment plan. And the treatment plans themselves are multifaceted, and it's important they don't get tunnel vision on one particular entity that's going to solve their headache problem, but it's a combination of multiple important factors. SMART is a mnemonic that we use to highlight key lifestyle factors that can be essential to the success of therapy. It's important to review very specific goals within each of these branches so that patients can come up with appropriate behavior modification to meet these goals. S stands for sleep. So you want patients to have a consistent schedule, appropriate number of hours for their developmental stage, avoiding naps, screening for sleep disorders like insomnia or sleep apnea that can be aggravating their headache condition. M stands for meals and hydration. And so you want a healthy diet, regular food intake, not skipping breakfast, specific hydration goals for their age, and always take into account their athletic activity. So athletes may need a higher level of hydration compared to kids who are not athletically involved. A stands for activity. So aiming for at least 30 minutes of activity, at least a few days out of the week, and working with patients to make achievable goals. So a sedentary patient may need to step up their activity level gradually over time. And then screening for things like elevated BMI that can, again, contribute to the overall burden of disease in these headache patients. R stands for relaxation. So there is an important interplay between mental health and migraine disease. So counseling patients on mindfulness or biofeedback techniques, and then screening for other issues that can play a role, like depression or anxiety, which often are comorbid with migraine. And then T stands for triggers. So some patients may find it helpful to keep a log to identify triggers for them. There are certain dietary triggers that can occur in some patients. And then screening for caffeine or other substance use as issues as well. Biofeedback, cognitive behavioral therapy, and relaxation training are some of the modalities that are endorsed by the U.S. Headache Consortium guidelines and do have evidence in effectively managing migraine at multiple stages of life, including in kids. You may need to re-emphasize to patients that their pain is real. It's not just in their head, but targeting their mental health or optimizing mental health is just one of the tools that can help improve their headache pain. The American Migraine Foundation is a good resource for learning about these approaches, and then more information can also be found on the American Headache Society's primary care website. I just want to highlight two options because we recognize there are barriers to accessing behavioral health. There's a shortage of providers. There's really long wait lists. And so a couple of options, and you should be able to access them with the QR codes if interested, are the Headache Relief Guide. And so this is a website that's specifically designed for adolescents, and it includes disease education and teaches relaxation and mindfulness strategies. And like we mentioned before, the American Migraine Foundation is a really great resource. It includes, again, educational resources on how to perform mindfulness exercises. It's also a really good resource for patients and families to explore other treatment options that are out there that they might be interested in and can discuss in clinic visits. So the next topic of acute treatment is acute treatment of migraine attacks. So we know that undertreating acute attacks does contribute to transformation from an episodic migraine to a chronic migraine, and thus greater migraine-related disability. Many patients with migraines can tell the difference between what's a mild attack and what's a severe attack. For a mild attack, NSAIDs, more nonspecific therapies, lifestyle measures may be enough to get that under control. But if it's more moderate to severe, a combination of NSAIDs plus a migraine-specific therapy like a triptan or dopamine antagonist may be necessary. The treatment plan should be individualized and include shared decision-making with the patient. And so we're usually trying to emphasize this stratified model of approach where they're targeting the treatment specifically to the type of attack that they're having. NSAIDs are one of the main things that we use in treating headache attacks. So typically ibuprofen at an appropriate weight-based dose, 10 mg per kg. There are several triptans. So these are your migraine-specific serotonin agonists that treat headaches. These ones are approved in pediatrics by the FDA. There's a sumatriptan naproxen combined tablet, zolmitriptan and sumatriptan in nasal spray formulations, rizatriptan in the dissolvable tablet, and then almotriptan tablets. Just to name a few. And then dopamine antagonists like prochlorperazine, promethazine, and metoclopramide. We do sometimes use ondansetron, so that's Zofran, which is helpful for nausea during a migraine attack, but does not target the headache pain itself, whereas the dopamine antiemetics are effective for both pain reduction as well as nausea. It is important to review with patients that early treatment with their medications leads to greater efficacy of the treatment. So you want to treat early in the attack for the attack that they're having. How do we choose which agent to use? There are multiple triptans with multiple formulations. Several of them, which we mentioned before and are listed again here, are FDA approved for use in pediatric patients. Sometimes insurance coverage plays a role in what you might choose. There are other factors that may be included, including the individual features of the attack or specific medication considerations. So these are the rest of the triptans. So there are 7 in total. Rizatriptan and zolmitriptan, those ones come in dissolvable formulations, so may be considered in patients who can't yet swallow pills. Sumatriptan and zolmitriptan both have nasal spray formulations. So in kids with significant GI distress or nausea vomiting, they may need something that's not swallowable. There are two triptans, naratriptan and frovatriptan, that are long acting and they have longer half-lives and generally a slower time to peak. And so in patients that have difficulties tolerating the other triptans or who have headache recurrence after the triptan wears off, the longer acting triptans may be more appropriate. And then you need to consider other medications that the patients are taking. Propranolol, for example, which sometimes can be used for headache prevention, increases the efficacy of rizatriptan. And so rizatriptan may need to be lowered in the setting of that medication being used. So it's important to give appropriate counseling on how to use the triptans, specifically the rule of twos. So for most triptans, the dose can be repeated after 2 hours, with the exception of those two long-acting ones. You don't want to use any more than 2 doses in a 24-hour period. And then we aim for 2 treatment days per week to minimize the risk of medication overuse headache. You may receive an alert about the risk of serotonin toxicity for patients who are prescribed triptans who are also on antidepressants. It is the American Headache Society's position that currently available evidence does not support limiting the use of triptans in patients who are prescribed SSRIs or SNRIs. So we prescribe these medications comfortably together. And then you want to counsel patients on side effects that could potentially happen, like tightness in their chest or face, feeling flushed or tingling, feeling malaise, upset stomach. Some of these types of side effects can be mistaken for an allergic reaction, so we want patients to be aware that this can occur. It's also important so patients can alert their provider when they have side effects that make them uncomfortable so that they can tell the provider, consider other treatments, rather than just avoiding the medications and not having an effective abortive regimen. There are some contraindications for the use of triptans, which include coronary artery disease, cerebrovascular disease, like history of stroke, severe liver impairment, or uncontrolled hypertension. So these are relatively rare overall in the pediatric population, but should be screened for. And then there is a relative contraindication in patients who have hemiplegic migraine or migraine with the brainstem aura, and often those cases may need more careful scrutiny by a neurologist or headache subspecialist to determine whether a triptan may be appropriate. A migraine action plan is essential for successful treatment in school-age kids. So pictured here is an example of the pediatric migraine action plan, or the PEDMAP, where they use the concept of red, yellow, green correlating to their pain. So green means go, the patient's functioning. What are they doing in the background to help manage their symptoms? Yellow, slow down or pause. They're starting to have some symptoms that interfere with their functioning. What are they going to do to intervene? And then red would be stop what you're doing. They're having significant symptoms that require urgent attention. So this is a customizable treatment plan. It gives the patients and families and the school clear instructions for how, when, and where to treat in the school setting. And then in this particular document, the reverse side also contains a lot of tips and tricks for families to manage in the background at home, at school, and just in general in life. A few pearls regarding acute treatment. So in patients who have significant nausea or vomiting, considering co-administration with an anti-nausea medication or the non-oral formulation of triptans like the nasal sprays or sometimes subcutaneous versions. If medicines are not working, you always want to make sure that you're verifying that they're taking the medicine at the onset of the headache and that the dose is appropriate for their weight. If an NSAID is not effective, you may need to add a triptan. If a triptan is not effective, you may need a combination of treatments or consider an alternative agent. If they have headache recurrence after their treatment, you may again need to consider combination therapy or those triptans that have the longer half-life. If they're escalating their use of abortive medications, you may need to consider migraine preventive agents and then again counseling on medication overuse. And then if they're failing treatment, that may be a situation where you need to consider referral to a headache specialist or again considering preventive therapy. So far we've covered education and acute treatment. The next topic is migraine preventives. Not all patients with migraine need a preventive medication, but it is good to have guidelines on when this should be considered. The American Academy of Neurology guideline recommends discussing prevention when patients are having 1 to 2 days per week of headache with moderate or worse disability. Other reasons that you may consider prevention would include migraines that are interfering with school attendance or activities. If the patients or families have a preference on migraine prevention, sometimes they come to their clinic visits very educated already on options available and they're interested in trying something. If the acute treatments are not working or causing intolerable side effects, you may have to shift focus to preventive agents. And then if they're escalating their acute medication use, which would suggest that their headache frequency is worsening, then prevention may be appropriate. But most children do benefit from acute migraine treatments along with just by behavioral and lifestyle changes and don't necessarily require this, but there's still a substantial number of patients that require this added layer of preventive therapy. Some options for preventive therapy include both nutraceuticals and pharmaceuticals. In pediatrics, we often see the nutraceuticals used first due to the common thought that they have relatively lower rates of side effects or adverse events and they're well tolerated. Riboflavin, magnesium, CoQ10, and melatonin, these are commonly used in this category. Riboflavin and magnesium have somewhat better evidence in this group in the pediatric population, but overall studies are very limited. Many headache providers will divide the dose BID. Some people will dose it once a day. It is important to counsel patients still on side effects of these medications, though. Riboflavin can discolor the urine. Magnesium can cause GI distress, like abdominal cramping or diarrhea. It is typically used in the chelated form to minimize that risk, like magnesium oxide tablets, which you often use. CoQ10, that one's expensive. Melatonin has conflicting evidence, but it can be particularly helpful in patients who have insomnia. And I just want to mention that Butterbur, which does have good evidence in migraine prevention, but because of changes in manufacturing and concerns about liver toxicity, it's not recommended by headache providers right now. And when you look at pharmaceuticals, the ones that are most commonly used in pediatrics would include your anti-seizure medications like topiramate, less commonly valproate, the tricyclic antidepressant, amitriptyline, and then antihypertensives in the beta blocker category like propranolol. Ciprofloxacin is used very frequently despite lack of controlled trial evidence, but clinically seems to be very helpful, particularly in the younger prepubertal children, and comes in a liquid formulation, which is advantageous for kids who can't swallow pills yet. Topiramate has an optimal dose of 2 milligrams per kilogram per day. You do need to counsel patients on other side effects that can come along with topiramate, and in particular, reproductive risk and contraception, often needing folic acid supplementation in your reproductive age females. Amitriptyline has an optimal dose at 1 mg per kg per day. That's the tricyclic antidepressant. Your mood medications always have black box warning for suicidality or worsening mood, and so that should be included in your counseling with those medicines. Propranolol has a contraindication in patients with asthma. Valproate, as with topiramate, carries a risk of side effects and reproductive concerns. And again, folic acid supplementation and contraception may need to be discussed. Out of these, amitriptyline and topiramate both have high to moderate levels of confidence in migraine prevention. And then propranolol and valproate have lower levels of confidence when you look at both the American Academy of Neurology as well as the American Headache Society guidelines. And then it's important to note that the doses here are optimized doses, not the starting dose. And so you need to uptitrate these medications gradually, slowly over time. So we're usually increasing them over a period of 2 months to minimize side effects and improve tolerability. The Childhood and Adolescent Migraine Prevention Study, or the CHAMP study, should be considered when prescribing preventive treatment. So this was a study that was designed to look at the efficacy of these migraine preventive agents that are commonly used in adults, but applying them to pediatric patients. It was randomized, double-blind, placebo-controlled, 24-week trial of patients who have migraine who were randomized to either amitriptyline, topiramate, or placebo. They all received education, an optimization of their as-needed regimen, and they met frequently with either study coordinator or nurse every couple of weeks. The children were 8 to 17 years old, and over 300 patients were randomized to the study. And ultimately, it was concluded early for futility because neither of the medications, amitriptyline or topiramate, were outperforming placebo. But all of the groups got better. So they were all meeting this primary outcome in the majority of patients where they were getting greater than or equal to 50% improvements in their headaches. So what we learned from this study is that the majority of kids who have a multifaceted treatment plan where you're working on education, optimizing abortive therapy, will have significant improvement in their headaches. And when this can be achieved, it can actually be sustained for years. So they followed this cohort, most recently have had 3-year data published where those effects in improvement have been sustained over time. So we use shared decision-making with patients when determining what pharmaceutical to add to their treatment plan. It doesn't mean that amitriptyline and topiramate don't work. They all work. They weren't superior to placebo. And if they have comorbidities that might also be helped with the medications, then that can be a factor in the decision that you make for choosing the agents. When talking about preventive therapy, there are some important tips. So you want to set appropriate expectations. The goal is control, not curing their migraine disease. We want to decrease the attack frequency, decrease their level of disability, and improve their response to abortive treatments. Preventives take time to work, so they may need 2 months of daily consistent use at an optimized dose before the benefits start to emerge. So it takes time. You want to mitigate side effects of preventive agents, especially with the pharmaceuticals. So again, we start low, we escalate slowly over time, and this can delay time to see the effect because you can't start at that optimized dose. And then always addressing comorbidities that will inform the treatment choice. So amitriptyline, for example, can help with insomnia. Topiramate can help with things like weight loss or patients with binge eating disorder. Prevention is also not forever, and this is particularly important to emphasize with concerned parents who don't really want their kids on a seizure medication or an antidepressant medication. So typically, standard practice is to treat for at least 3 to 6 months once they've achieved an adequate goal in terms of their headache control. And then again, from the CHAMP trial, we learned that when they come off this medication, those effects can be sustained for years. If considering involvement of a headache specialist, letting patients know what to expect can be helpful. So headache specialists may incorporate novel therapeutic options, like enrollment in clinical trials for CGRP blockers or antagonists that are actively being studied. Procedural management like Botox injections for migraine or nerve blocks. And then neuromodulation devices. These are approved and effective for acute treatment and preventive treatment in adolescents. Pictured here, the top picture is the Nerivio device. So this is remote electrical neuromodulation. And that bottom picture is GammaCore, which is non-invasive vagal nerve stimulation. These devices are appealing in many ways. They're not medicinal, so minimal from a side effect standpoint. There's no risk of overuse headache with these devices. Kids like to use devices, particularly when they don't want to use medications. And you can find more information on the American Headache Society's first contact website for these, particularly because they're growing in popularity. A lot of times patients and families are coming in asking about these, and it may be something that if you're looking to incorporate in your own practice before they even get to a neurologist or headache subspecialist, you can find more information on how to do that. As of last week, there are 17 clinical trials actively recruiting for the newer migraine therapeutics in the pediatric age range. So these are fantastic medications. They're migraine specific and will give us a lot more options, but we still need to wait a few years to see the results and what they're going to do. Currently, UPMC is a site enrollment for the Emgality, which is a CGRP antibody for pediatric patients. The last part of the talk, I want to discuss a common concern with managing adolescents with migraine, and that's the question of contraception. The risk of stroke in migraineurs is overall low, but is slightly higher than the general population. And migraine with aura does increase that risk further. When you look at adults, migraine aura increases stroke risk with an odds ratio between 1.6 to 2.4 times more likely. And then depending on the other comorbidities that factor in, patients with migraine who are on an estrogen-containing contraceptive, that stroke risk can go upwards to 8 times more likely. Stroke in pediatrics is rare, but pediatric patients with migraine, again, have an increased risk of ischemic stroke. So the WHO, ACOG, and the USMEC, they all agree that combined hormonal contraceptives should be avoided in females who have migraine with aura. But the International Headache Society does make an exception for those who just have simple visual aura and the use of low-dose estrogen-containing contraceptives. So that's 20 micrograms or less. Data does show that the risk of ischemic stroke associated with estrogen is dose-dependent. And so the odds ratio, if you look at just the progestin-only pills, is at baseline. So there's not an increased risk of stroke in that medication. Low-dose estrogen contraceptives, it is slightly increased at 1.7 times. But if you look at those higher dose estrogen, as you go up on the estrogen component, the increased risk of stroke it increases significantly. And so more data is needed to completely understand the risk of stroke with the low dose estrogen formulations, but in certain patients, there may be room to consider use of those agents depending on their needs. So for patients with migraine with aura deciding on contraception, the main goal often is to minimize their stroke risk. And so we consider the non-hormonal or progestin-only options as a first choice. For patients who have migraine without aura, the goal may be more to decrease their hormonal fluctuations. So hormonal fluctuations can trigger migraine. Monophasic low-dose estrogen contraceptives or vaginal rings with a low-dose estrogen, and then progestin-only contraception, again, are our favored agents. For any patient who has a change in pattern or a new onset aura after starting a contraception that's combined hormonal, they should stop that agent right away. So to summarize, the main objective for these patients is to recognize migraine disease, rule out secondary causes, educate patients about the disease. You're going to come up with an individualized treatment plan acutely for attacks, lifestyle modification, and preventive management. And then remembering the other tools that are available to help get symptoms under control, including behavioral therapies, nutraceuticals, medical treatment, and anything else that might help limit their migraine-related disability. This slide is to acknowledge a superb group of headache providers that really spearheaded this effort to educate primary care providers in caring for migraine patients. And then I do want to just draw your attention to First Contact as a website. This was built as a comprehensive program to educate people caring for those first presentations of migraine patients. And then it contains the most up-to-date information on the treatment, how to recognize, and what our understanding of migraine disease is right now. And there's information and formats for all types of learners. You can delve more deeply into all of the topics that were introduced or discussed today. And I hope this was informative for your practice as you continue to care for patients with migraine. And that's it.